Thank you so much. Good morning, everybody, and thank you for making it here for what still feels quite early in the day. I love cytology. It's the best. It's shapes and colours. Even I can do that. And to be perfectly honest with you, I think cytology is one of the things that you can get so much out of for relatively minimal input, even during a busy practice day. And actually, there's a lot of ways that you can save your clients and your patients not only time, but money, doing a little bit of cytology really well and screening some of your samples in practice. So my brief for today was to do a few talks, the first of which, the inevitable lumps and bumps. So a little bit about fine needle aspiration techniques first. First, try and get the perfect sample, whether you're going to be looking at this yourself, in which case you have a vested interest, or if you're going to be sending your samples out to an external laboratory. Us clinical pathologists love you if you give us really nice samples. Sometimes it's hard to know what sampling technique is going to get the best from any individual mass, because each mass is different. There are some that are going to be really bloody when you aspirate them, and in that case you may not need much in the way of active aspiration. Harder masses often need a little bit more welly to actually get some of the cells to come off them. So what I find is that it may take a mixture of different sampling techniques to get that one slide from that one mass that's the perfect combination and gets you the best intact cell yield. So you may wish to start with a blue needle and just a passive redirection technique, then stick a syringe on it and give it a little bit of suction, and then maybe swap over and use a green needle for the next set of aspirates. Potentially a bit more cellularity, but a bit more likely to bleed. Hopefully somewhere in that combination there will be that perfect match of needle and passive or active aspiration that should get you the ideal sample to then send out. If you are taking active aspirates, one thing that I would say is when you actually have your needle and you've taken your suction biopsy, make sure that all of the suction is released before you pull out of the mass. Otherwise, your beautiful sample ends up in the barrel of the syringe and there's no way of actually reclaiming it. As I say, quite bloody masses, you may find that although the cell yield doesn't look quite as high, that a relatively gentle technique with a blue needle may actually get you the better sample. So I'm sure that you'll pass masters of getting the ideal aspirates. Personally, if I, having said, use a combination, I always found I got slightly better samples using blue needles and a little bit of active aspiration. So if your right hand is dominant, you're fixing the lump or bump that you're aspirating with your left. Whether or not you actually sterilize the surface of that depends a little bit, I think, on the lesion. But I think if there's any doubt, then potentially just a little bit of a scrub on top won't hurt. Introduce and use your fixing hand to give you some idea of how far into the mass you actually are. At the moment, you've just introduced the needle on the syringe, you haven't done anything with it. Once you're well seated, at that point, draw back. You don't need a 5 or a 10 ml syringe. You're not trying to actually remove the mass via the needle. You're just trying to get a few cells. So just a small syringe is perfectly adequate, a 2.5 ml syringe. Give it a little bit of a tug back, release, and redirect. Do that a few times so that each time you're drawing back, you're actually aspirating from a slightly different area. The histopathologists hate it when they get biopsies that have been previously aspirated because they can see the needle tracks where we've been gathering these cells. Once you've redirected a few times, again, no pressure at all on the syringe, gently withdraw the needle. Take the syringe off the needle at this point because the best part of your sample should now be in the hub of your needle. Draw some air back into your syringe, and then you're going to huff it out onto one of your slides. To make life easier, because you're now going to spread this sample, I think it makes sense to try and actually get your sample at one end of the smear rather than necessarily going for the middle. As you make the smear, you're then going to use up the rest of the slide, whereas if you're only starting halfway down the smear to begin with, you kind of miss out a little bit on surface area. As if by magic, a sample appears. Oops. And one thing to say is that you don't need a massive amount of material on the slide that you're making. If you have a 2.5 ml syringe full, that doesn't all need to go on the one slide. We're not making black pudding. You know, we want something we can see through. So that's probably about as much as you'd want, no more than that. So this can be done either, as I say, just with you identifying the mass, fixing it with your non-dominant hand, and sampling with the other, so really doing it by touch. If things are a bit deeper, or if you're worried about structures nearby that you don't want to prang, if your lump or bump is ridiculously close to the carotid artery, you may not just want to go for the jab and hope technique. You may want a little bit of guidance. And so with ultrasound guidance as well, fixing the mass, really identifying where it is with the probe, with the non-dominant hand. What I would say is there's often quite a lot of ultrasound gel around at this point, and it's really, if you can, quite important to get an alcohol wipe and to wipe the gel away from the area that you're going to be aspirating through. Lubricant gel and ultrasound gel really does cause a huge number of problems when it comes to look at the cytology if it accidentally contaminates the sample. When we're thinking about on a budget, if you have had to ultrasound things to really try and identify where the lesion is and to get the best samples, it's suddenly become really quite labor intensive. So I think the thing that I want you to think about with this slide when you're thinking about a budget is how many people did this involve to get these samples? We've got the person taking the sample, we've got the person looking after the animal, the sedation or anesthesia are involved in this. This has suddenly become quite an expensive enterprise for the owner. So I think especially where you've had to sedate or anesthetize an animal to get samples, it's so important that you make the absolute most of it. And this is where I love our imagers, because they take us at our word, and when we say, give us multiple samples, they really give us multiple samples. You asked for it, here you go, 19, knock yourself out. We like that. Firstly, it means that if there is a diagnostic sample, even possible from this mass, the likelihood is it's going to be somewhere in those 19. And you know what? Once we've put them through the stainer, we've got a fairly good idea of which ones are going to be the most cellular, because they're the ones that have the blue areas on them. Nuclei stained blue. So I think the first thing about the budget is if you're taking samples, take as many as you possibly can. Even if for billing reasons you don't want to submit them all, take more than you need and retain the rest, just in case yours comes back as non-diagnostic. The other thing that is so important is if this is a once-only opportunity, if this is a pre-treatment sample, and you're never going to have that untouched mass again, oh, just go wild. Take as much as you can, because you'll never be able to go back. For example, pre-antibiotics. So, once you have your sample and you've made your smears, I put it to you, which is the best way to prepare the majority of your aspirated samples? So, the question is, A, spread the sample as thickly as humanly possible so that all of the material is used and you've got as much as possible per slide. B, spread all slides using a blood smear technique to ensure that the sample is nice and evenly distributed. C, use a flat slide over slide technique. Or D, use a needle drag technique to give you a starfish type arrangement. So go for it. Which is your preferred technique? I have to say that for some of these, there isn't one right answer. So we'll see what we think. Vast majority of the room are my favorite people. So those of you who like the slide over slide, oh, I am so with you. It just seems to give a nice distribution. I'll come on to why some of the others aren't quite so good. B, blood smear technique, there's an argument for it. You're not wrong, I'm just saying you're not the most right. Those who voted A and D, see me after. Basically, it's really tempting when you've got a really good aspirate to put it all on one slide and say, yes, look at that, it's amazing. The problem is those really thick smears, once you actually get them stained, you end up with, surprise, surprise, a sample that's so thick that you actually can't see through it. So in this case, what we have here is a sample that does have cells. Look, I can see this, and I hope that you can all appreciate individually the morphology of these. No, nor can I. Those are small dark dots. Are we agreed? Anything that's stuffed into a thick background tends to condense, and you cannot see within it. So try and just minimize how much you're putting on the slide. Those of you who are doing a blood smear type technique, that's absolutely fine if the sample that you've got is quite bloody. If you have a relatively low volume sample, if you've just got a light spattering on your slide, if you then try and blood smear that, in my experience, the cells will want to rupture a little bit more than if you just drop a slide flat on top and pull apart. Sometimes it works really well, sometimes it's a little bit fragile. So for the slide over slide technique and for the health and safety aficionados in the audience today, obviously this person is wearing an imaginary white coat and imaginary gloves, and we would never ever make slides without wearing both of those things at any point in time. So a small dot of sample goes on there. The top slide comes in and is gently placed on top. You are not pushing down. If you push down, you'll rupture it. You've ruined your slide. You'll have to go back to the animal, and that costs money. Very gently push off. And hopefully then at that point, you've got, because you started at this end of the slide, you've got a nice full slide on the sample receiving slide. And you've also got a nice full slide on the spreader slide. So, using that technique, minimum number of slides that you can generate. It's not one. How did this person spread the slide? With their tongue? Where's my spreader slide? I'm missing a slide. Minimum 2. I checked just to make sure it wasn't me. So I looked at all of the other labs' submission requirements and charging, just to make sure that there wasn't a lab out there that charged you 50 pence for one slide. No. Minimum of 3 is what I found in all of the different lab charging methods. A single slide is extremely lonely. Don't send them out to external labs on their own. They need a companion. If you're using impression smears, so taking tissue from a lump or bump that you've biopsied, and then making footprints onto a slide, again, keep going. Don't just do one smear. Do several slides. The reason being that the further down you go, the tackier it gets. and the better the cell yield. So actually, the last footprint slide that you make is often the best. And if there are spare ones, keep them in case there's extra testing that you need to do when you've got your cytology back. So, again, in terms of sampling, which of these is good practice? Putting thick samples in a slide holder before they're dry, because it keeps them nice and moist. Putting the slides in the same bag as the histopath sample, because that way everything's together, they're not going to get separated. Staining a slide with DiffQuick or RapidDiff for a look, and then sending it out to the external lab. Or staining a slide with DiffQuick and then never including it with the rest of the slides to go out, because after all, you've ruined it. So which of those do you think is good practice? And again, there may be some differences of opinion. Right, let's see what you think. You're my kind of audience. Yes, please. If you have the animal in front of you and you're like, I'm not sure whether or not this is going to be a diagnostic sample or not, by all means, stain one, if only to check that you have slides before you send out the submission and get billed for it. Include that one, because that might be the only slide that actually had cells on it. If I don't like your stain, I'll take it off and I'll put my one over the top. Don't put wet slides into the slide holders. Again, it really condenses them. Sometimes we get joint fluids that were submitted the day before they arrive in the lab the next day, still wet. It's revolting. Firstly, you can't get them out. And secondly, anyway, don't. If you can try and keep cytology away from formalin fumes, because it gives them a kind of a washed out appearance, it loses some of the internal detail that you'd really like to be able to look for neoplasia. So do, by all means, check a slide. Particularly, again, if you've got an animal that you've had to anaesthetize or sedate to get those samples, make sure you've got something before you wake it up. And as I say, every lab has a different way of billing for cytology. Basically, pick a lab whose cytology you like, and then adapt your sampling to make the most of the lab. Take advantage of us. When you come to do staining in-house, we all have pretty similar rapid stains, lots of different trade names. They all have a relatively similar performance. From a budget point of view, and I know that you know this anyway, but use tall, narrow, upright jars to put your rapid stain in. That way you're using less volume, and that way you're happier to throw it away and replace it when it needs throwing away. If you're using really big jars, that's a lot of money's worth, and you tend to want to hang on to it for much longer than is perhaps ideal. The first jar, as you know, is alcohol. Apparently, if you leave the lid off alcohol, it goes away. Make sure that the first jar in particular has a really good, tight, preferably screw-top lid. It will save you money through the fairies just taking it away. If you're not sure where you are with your stain, it might be all right, it might not. Use a blood smear just to check how your stain is still working. Blood smears are nice and standard, and that way you've got some idea as to whether it's exhausted or you can still get a little bit more mileage out of it. When you're initially looking at your slides then, under low power, even before that, you hold it up to the light and see whether or not you can see blue bits. The blue bits are where the cells are going to be. You put it under low power and you look for the best area to start to assess it. Do not go for the really thick areas. We've already discussed why. I can see that there are cells there. I have not a clue what they look like individually. So actually, sometimes it's the thinner areas towards the edge of the smear that gives you the best intact cell yield where you can assess the morphology. Look for that perfect area between too thick and the cells are ruptured. It's often a little thin band somewhere towards the edge of the sample. When we're doing our assessment in-house, the first major category division, if you like, is trying to decide whether your lump or bump is inflammatory or if it has a tissue population or a bit of both. Now, this is quite a big branch in terms of you deciding how you're going to manage this individual or what further investigations you're going to do. So I think being able to look at the sample and say, yeah, this is an inflammatory cell type that I recognize is really handy. Sometimes, and we'll come on to this in a bit more detail, it's enough to know what the mass is not. Anyway, learning to recognize the inflammatory cell types can actually give you the diagnosis in quite a few circumstances, especially when we're talking about cutaneous lumps and bumps. If you can do those in-house, confidently, that's going to drastically reduce what you feel you need to send out. Sometimes it's nice just to get a bit of reassurance. The one thing that I would say, though, is that I am carrying my crusade against macrophages around the UK and around Europe. I hate macrophages. If we could nominate one cell type to do away with and we'd still be okay, the macrophages get the boot. No two ways about it. They're terribly helpful. They try and tell you what's going on, but then if you irritate them, they pretend to be neoplastic, and that's just not on. Be careful of macrophages. The other thing is, if you have a bit of mixed population, inflammation and tissue cells, funnily enough, if you stick tissue into pus, the tissue gets quite annoyed, and it expresses its annoyance by taking on some criteria for malignancy. So be careful of over-interpreting tissue changes if they're sat in a very inflammatory environment. If in doubt, send it out. So, first lump. The question in the next voting slide is going to be, what is this? So, this is an aspirate from the mass on the head of a 3-year-old cat. And we have just a little bit of giveaway, a red cell there and a red cell there for size comparison. We have these going on. So, what is that? Is that macrophage-rich inflammation? Are those non-degenerate neutrophils? Or are those degenerate neutrophils? By the way, I'm loving that everybody's voting quickly. You're amazing with those things. Thank you so much. Oh, you see, this is why it's worth putting these things in. You are right, you wonderful green people. Those are degenerate neutrophils, but people would be forgiven for thinking, actually, do you know what, those are quite spread, those could be macrophages, or even, I can see that they're neutrophils, but not quite sure what's going on. So degenerate neutrophils are those neutrophils that were formed correctly, they've come into an area of tissue, and since they've arrived, something dreadful has happened to them. Poor things. The things that they don't like are bacterial toxins, and that can be important for lumps and bumps. There are other things that they don't like that I would hope that you wouldn't be aspirating from a lump or bump, and that would be pancreatic fluid, bile, or urine. If you get those on a lump or bump, something's gone horribly wrong. So for lumps and bumps, it's often bacteria that cause neutrophils to become degenerate. What happens is the neutrophil starts to take on fluid, and that fluid makes a nice, smooth nucleus spread and fray and become more open and ragged looking. To give you some idea of what the two types of neutrophils look like side by side, on the left-hand side there we've got an area of sterile neutrophilic inflammation. These neutrophils are desperately happy. They have left circulation, they've come to tissues, they're hanging out together, nothing dreadful has happened to them, so they look just the same as they did when they were in blood. They have very dark staining nuclear chromatin with segments and thin filaments in between them. They're having a ball. These, on the other hand, it's like immediately after the first 15 minutes of Saving Private Ryan. These neutrophils have been through it. You can vaguely make out that they are still neutrophils because they still have the segmented nucleus, but oh, look at the poor loves. They're ragged, they're bloated, they're spread. So they've undergone changes that have been a direct effect of the fact that they have been doing their job. They came into an area, they weren't expecting it. There were bacteria there were toxins. Bad things ensued. So the point is, if you have really crispy-looking, beautiful neutrophils, it makes it slightly less likely that that's an active, full-on bacterial infection. For lumps and bumps, especially in skin, if you have neutrophils that are very spread to the point that they do begin to look a bit like macrophages, spend time looking for the cause, look for bacteria. Macrophages themselves. So we've got red cells here in lumps. This is a macrophage, so they're quite large cells. Again, lumps and bumps, they're often quite activated. We've got a nucleus that's a bit more open and rounded and spread than the nuclear chromatin of the neutrophils. So here is our macrophage, and I hope that's not the next question. What cell type is this? Phew. So what's your diagnosis? From this macrophage, does this cat with this nodule have a fungal infection, a gram-positive bacterial infection, a gram-negative fungal infection, a mycobacterial infection, or is that in fact a mast cell tumour? You'll notice that the questions are getting slightly meaner. I'll be positively sadistic by the end. Ooh, nice split. I really like it when this happens because it means that it was a sensible question to put in. Fine. So, this actually is a mycobacterial infection in this cat. Now, fungi, funny things, because they have a waxy coat, they don't pick up diff quick on the coat, so that you often have non-staining areas on the margins of fungal elements and yeasts. They often do have some kind of central area that does pick up stain, however, and they tend to be on the larger size. With these, what we have is a bunch of non-staining rods. These are not picking up the diff quick or the rapid diff at all. And again, that tends to mean a waxy or lipid-rich coat. And that's pretty typical of mycobacterial infections. And mycobac is so waxy and so difficult to deal with that, you know what, using neutrophils against it is a bit of a waste of time. So this is why we tend to recruit macrophages, which you're going to use for heavy lifting and for getting rid of things that are difficult to shift. And the macrophages are so helpful in that not only do they gather stuff for you, they present it and say, look, this is what the problem was. This is a rapid type stain. We can tell nothing about the gram staining characteristics from this stain type. If you want to know if it's gram positive or gram negative, you need to gram stain separately. So if you're seeing mixed inflammation and you have macrophages, just pause and look to see what it is that they're gathering. So for example, if you're aspirating an area next to an sort of soft tissue lump that you think may be a bruise, it's not at all surprising to find macrophages downstream of that. Downstream? No, wrong way. Upstream of that, so draining that, that actually are recycling the red cells that have poured into that bruise. Somebody needs to tidy up, and the macrophages are the ones that are going to help do it. And again, it does tend to be things that are more difficult to shift, so fungal organisms, mycobac. In this case, this is from a shallow ulcerated skin lump. And in this case, it was an impression smear rather than an aspirate. But we have a macrophage in a dog where there was a very strong clinical suspicion of leishmaniasis anyway. If you need to go and look for something specific like that, ask the macrophages what they've been tidying. And in this case, we have the classic kind of V-shaped organisms packed within the macrophage as it tries desperately and fails to deal with it. Other inflammatory cell types, again from lumps and bumps, can be quite helpful. We have examples of eosinophils over here next to neutrophils. Neutrophils often have a slightly pale pink staining cytoplasm with diff quick or rapid diff. Eosinophils should be unsubtle. If you're looking at a cell and trying to determine whether it's a neutrophil or an eosinophil, again, being probably slightly sexist about this, but if you imagine that a 7-year-old girl is allowed to decorate her room for the first time, which colour would she pick? If she goes for the really, really, really deep pink colours, it's that kind of pink that you want from an eosinophil in the granules. It shouldn't be something subtle. It shouldn't be pastel shades. It should be pink. And when we're seeing eosinophils in lumps and bumps, it's often associated with hypersensitivity type reactions or arthropod bites. It may be that there's inflammation close to a mast cell tumour and we're seeing a consequence of that. In cats, it can be linear granulomas. But either way, eosinophilic inflammation, hypersensitivities, parasites, top of the list, and unsubtly pink cells. Inflammation with lymphocytes, we don't see fantastically frequently. If we have a nodule or a lump or a bump and we aspirate it and we get small lymphocytes, often we find that this has to do with a vaccine site reaction or an arthropod bite. It's unusual to get solely lymphocytic inflammation in very many other circumstances. We can get cutaneous lymphomas, but those are predominantly large lymphoid cells and they can look quite bizarre. So basically, if you've aspirated a lump and you're looking at small, normal-looking lymphocytes, is this somewhere where it was vaccinated recently? Have you taken a tick off this individual in the last few days? And if you find that your lump or bump aspirate actually isn't inflammatory, then by definition it has to be some kind of tissue cell. And again, when you're looking at your own slides on a bit of a budget, I'm not expecting everybody to be able to diagnose absolutely everything. I still can't. I still have to get the textbooks out every now and then as well. But sometimes having some individual cell types that you do recognize, the common ones, that it's almost like recognizing a neighbor in the distance. You're like, oh, it's you. I haven't seen you for a while. Then again, doing stuff in-house with those ones can give you a bit of an advantage. I would say as well, when you are looking at your own slides, do consider the size of the mass, the position of it, and the rapidity of the growth alongside the cells that you're seeing. So this is why it's often better if you took the sample, that it's you that looks at it as well. So we'll start off with the easy ones. So this is a subdermal mass, so it's 1,000 times overall, so 100 times oil immersion, 10 times eye lens. 10 centimetre diameter, slow growing, and this had a greasy appearance on the smear. So what is this? Is this a lipoma? Is this a liposarcoma? Or are you looking at sebaceous material there? Yes, fantastic. So the vast majority of you went correctly for lipoma. Liposarcoma, there's, easy to fox people say, oh, are you sure it's not a liposarcoma? Because that would be a bad mistake. So having the courage of your conviction sometimes to go, no, pretty sure it's a lipoma is a good thing. However, sebaceous material is another thing that can also have quite a greasy appearance on the slide. So how do we know for sure that this greasy appearing thing was a lipoma? Well, we've got these wonderful, this is a lower power magnification, wonderful adipocytes. And if ever the form of a cell followed its function, it's these. These are beautiful cushions of fat. You can see what they're designed for. You can see the fat inside them. The nucleus is really shunted off to one side of the cell, and it's teeny tiny compared to the rest of the cell. These beautiful large cells just tell you what they're for. And they're all very samey and they're easily recognizable. So lipomas are ones that we're quite happy with, which is why it makes me sad and occasionally almost violent when I hear people say, I took an aspirin and I put it on, it was greasy, so I said it was a lipoma and I put it in the sharps bin. No. May not have been adipocytes. Small chance, but still a chance that it was something else. So do you know, we don't see liposarcomas fantastically frequently, but what's worrying is they can have a similar clinical appearance. They may feel a little bit harder, but you know what, when you aspirate them, you can get quite a greasy appearance on the slide. And it's not until you dry it and stain it that you realise that, hang on, those aren't adipocytes. Now, at that point, I think that you have more than earned your money, because it may be that you look at that and go, I don't know what's occurring there. But the point is, they're not adipocytes. This is not an okay lipoma that it's perfectly okay to leave. This requires attention. This is not what you were expecting. And again, if this comes from a 10 centimetre mass, if this was on me, I'd want it off. So you may not have the end answer, but you have your next diagnostic or interventionist step. It needs to come off. So, other lumps and bumps. This is a dermal mass. This is just noticed in a 10-year-old crossbred dog. What is this? And again, we have a neutrophil there for size comparison. Ready to vote? Is this a well-differentiated melanoma? Ooh. A poorly differentiated melanoma? Does this show macrophages and stain precipitate? Or is this a mast cell tumour? Decisive voting. I like this a lot. Bless you. Vast majority have gone for mast cell tumour. Vast majority of you are right. But we also have people here who have been, hang on, melanomas. I know there's something about granules in melanomas, and I know that Kathleen is just very slightly evil, so she might have put that in, even though I genuinely think it's a mast cell. And if it's possible that it's a melanoma, she could be even more evil and put in a poorly differentiated melanoma just to double bluff me. Macrophages and stain precipitate, I'll try that again. Stain precipitate gets everywhere, so that's not unreasonable. And for those of you who have courage of convictions, and it's, as I say, it's like recognizing a neighbor in the distance. If you don't overthink it, that's a mast cell tumor. So the commonest cells that we see in mast cell tumors have pink to purple staining granules, and they can spill into the background. To some extent, spilling into the background, it can make it quite difficult to see what's mast cell granule and what's actually stain precipitate. Stain precipitate can be quite lumpy, it can be quite rounded. It tends to be quite sort of black staining, whereas the mast cell granules are going to be somewhere between pink and deep purple. Also, they're quite fine. Melanin granules, just for interest's sake, because we don't see cutaneous melanomas fantastically frequently, they are small needle-shaped black-green staining granules instead, so there's a bit of difference in shade there. If it is stain precipitate, what we tend to find is that the precipitate washes up against the edges of the cells and it doesn't colonize the interior of the cells in the same way that mast cell granules do. We struggle, in fact, we often don't try with cytology to really try and classify mast cell tumours into well-differentiated, intermediate or poorly differentiated, because there's quite a lot of overlap in behaviour, and even histopath is finding it quite hard as well. Mast cells that aren't particularly well differentiated can look quite like macrophages, and so here are two recent examples of mast cell tumours where some of them have pretended to be macrophages. So under those circumstances, do have a really good look around and just ask, are any of you going to own up to the fact that you have granules? It takes a little bit of time. So we have a small, round, hairless mass on the ear of a 2-year-old mixed breed dog. Beautiful, beautiful cells. Nice aspirate. Is that macrophage-rich inflammation, a histiocytoma, a histiocytic sarcoma, a mast cell tumour, or a dunno but it's bad? It's nice to see who took the dunno but I don't like it escape route. That's absolutely fine, you send those out. This is absolutely a histiocytoma. It is a nice benign lesion, and what we tend to find is that benign lesions tend to be even in size and shape. The same cells doing the same job are perfectly designed, and they should all look the same. When you have things that have gone wrong, where things become malignant, growth inhibition is switched off, variability is allowed. So if you do see a population that you can kind of link together, but there's a lot of variation in their size and shape, and they're not inflammatory cells, what gave them permission to be different? You need to be suspicious. So taking the histiocytic theme, if we look at a malignant histiocytic tumour, so this is a malignant histiocytic tumour, a retriever, I suspect it may have been a flat coat, but I'm not sure, elbow mass. And in this case, we've still got blue-grey cells, we've still got the same nuclear chromatin that we had with the histiocytoma, but are we agreed that those are really quite different in size and shape? There's a lot of variation there, and that's not permitted. We've also got a mitotic figure in the middle there, showing off the fact that it's proliferating. One by itself is not a bad thing, but if you're seeing a lot, and especially if they're uneven, that's showing off. We don't like that. Other examples, just to give you, again, the overarching idea that cells that are doing the same job should look the same. On the left there, we have some really well-differentiated fibrocytes in a mature area of fibroplasia that look pleasingly like tadpoles in a feeding frenzy. Very samey, compared to what could well be a fibrosarcoma, not really sure, but a mesenchymal malignant tumour on the right-hand side here, where, again, we've got elongated cells, but those are all doing whatever they please. It's like San Francisco in the 1960s. Everybody's different. That tells you they're doing what they don't care. And that lack of care is something that you can see on the cytology. They're behaving, they're absolutely not. So when we're looking for signs of badness, we're looking for variation in cell size, nuclear size, and what we're also looking for is the cells showing off that they are, in fact, coming up to an active phase of cell proliferation. So the presence of nucleoli, which are these dark dots here, tells you that they're active. And not only that, but if even the nucleoli have variation in size and shape, refusing to obey rules of symmetry, you really have to look at those cells with deep suspicion. You may not have an answer for them, but that is not okay to leave on the animal undisturbed. That should provoke a conversation with the owner. Last one. Cutaneous mass, 2 centimetre, fluctuant. The aspirated contents appeared grey and flecked, a bit like the world's worst toothpaste. What is this? Is this inflammation? It's an abscess. Is this a histiocytoma? Are these squamous cells, so it's a squamous cell carcinoma? Or are these squamous cells without nuclei, so it's got to be a benign epithelial tumour or a cyst? What would you prefer as your option for that? Oh, super. You know your stuff. These are anucleated squamous epithelial cells. Cells without nuclei cannot, by definition, proliferate themselves. So they're often derived from a basal membrane layer that you haven't seen there. Basal membrane? No, basal cell layer that you haven't seen there. Anucleated, big, angular squamous epithelial cells, when they're all together, give you the most revolting toothpaste-like, slightly gritty, sometimes flecked with black appearance. They can be quite inflammatory if the cyst has ruptured. But the point is there are no nuclei there for you to assess criteria for malignancy. Just to compare that with its evil twin, that's what a squamous cell carcinoma would look like. It's a million miles away from the anucleated uniformity of the sebaceous cyst. We still have large glassy amounts of cytoplasm, but we have nuclei in cells that really should be old enough that they don't need their nuclei anymore. Not only have they retained them, but we have variability. A huge amount of variability within the same cell type. So for screening, I think that's probably all we need to do. So take-home messages very quickly. Are you please, pretty please, going to write really good descriptions of what you've aspirated? Whether the sample stays in-house and it's you that looks at it, or if it goes out. Are you going to have a look at how you'll build for cytology when you get home and make the most of it? Do take advantage and tell them I said so. If you are looking at your own samples, is it inflammatory cell type that you recognise? And if it is, can you see the cause of the inflammation? If it's not, then are they a cell type that you're familiar with? Do they have characteristics or criteria for malignancy that should concern you? Thank you very much.
Thank you very much, Kathleen. I'm sure everyone will agree that was a very amusing lecture. I've got a couple questions through. I've also just got a bit of feedback. You've got a fan in the audience, a great lecture, fab speaker. Thanks, Kathleen. So,
Money's in the post.
And then I've got a couple of questions about lipomas. So I'll just try and combine them, actually. The first question is, what's the best way to prepare a slide of a suspected lipoma? And this person, once they've scanned their slide, the fatty tissue, they feel everything has disappeared and there's no cells left.
Yeah.
And the other one, I think what he or she is saying is they're avoiding putting it in the first diff-quick alcohol stain. And then,
I feel your pain. So just to let you know what we've tried and failed, we have tried hair drying low heat setting, that doesn't work. Hair drying high heat setting, that doesn't work. We've tried leaving it on the side to dry overnight, that doesn't work. We've tried skipping the fixative, kind of works, but sometimes you still lose them. I don't have a really good answer apart from make lots. And often I think if you do actually get a little lump of cells out of a lipoma, you can almost see it standing proud on the slide. So if you can only see grease spots, maybe take a few more aspirates and just keep going until you get a little tiny lump. But yes, whoever answers that question in a reliable fashion, please tell me, I'll pay. No idea.
Right here. And then the next question, can you recommend a Teach Yourself Cytology for Dummies book? It's another difficult question. Try to find an easier one.
Do you know what? We've relatively recently gone from a situation where there were very few really good, well illustrated, that's the key, it's the photos, cytology books out there, to now we've got a couple of superb ones. Rose Raskin's book is my personal favourite when I don't know what something is and I have to play Snap. I'm not necessarily sure it's for dummies, but pretty much everything is in there and she's constantly adding to it. Cowell and Tyler is the other one that I really quite like. If you're like me and have a very short attention span, some of the what's your diagnosis type things I find very helpful as well, because then you're dotting around the place in a bit of a random fashion. Yeah.
Right, yeah. Thanks, Kathleen. Next question. In the histiocytoma versus histiosarcoma sample, there was one bad cell amongst other normal ones. Is there a risk of diagnosing a histiocytoma and missing a couple of bad cells?
I have to say that histiocytomas belong to the same family as macrophages, and therefore, although I haven't said so, they're also on my I don't like you list as well. Most of the time, if you have even cells in a histiocytoma, the odd slightly larger one, meh. If it comes to not so much lumps and bumps though, but neuroendocrine tumours, so things like thyroid carcinomas, adrenal tumours, you can get same enormous cell, and that actually does give them away. So under the histiocytoma banner, not an issue. They're allowed to have a bit of variation. But other tumour types, it can be an issue.
Okay. And with regards to the lipoma, Kathleen, I don't know if you do this, but from my point of view, what we do is we have the slide unstained, and we add a couple of drops of methylene blue on top of the fat. And then you put a cover slip on top of that. and you have a look at that, because what the methylene blue will do, it will stain mast cell granules, for example, so that you're not going to miss a few mast cells that might wash off during the staining. And then if you do find suspicious sarcoma cells or something like that, we do put them through the stainer, and most of the time, although you'll lose the fat globules, we find that most of the time the actual cells do stick around, just normal fixation, normal staining. That's my experience.
A cunning plan.
Yeah. So that might help if you've got access to methylene blue. Yeah. Well, thank you very much, everyone. Thank you, Kathleen.
Thank you.
And enjoy the morning.